Okay, so I think we're going to get started with the, so if you can just follow in your handout. Hello? We're going to get started. We're having a little bit of technical difficulties, but HIS is going to come over and figure that out. But in the meantime, we're going to just start, if you could just follow in the handout. This is Neeru. She was formerly one of our residents, who's now one of our esteemed cardiologists.
Thanks. Thank you guys for hanging out until 5 o'clock in the afternoon. We'll go through. Can people hear me in the back? Yes. What we'll do is I'll start with the handouts. There's a bunch of meds at the end. We don't necessarily have to go through all of it in detail, so we can take some time on the tachyarrythmias. But I put them in there because, just as a reference, if we have time, we'll go through them. If it starts to be like dinner time, we can move on. The topic that was kind of that sounded kind of interesting and definitely something that you guys see pretty frequently in the emergency room and actually across the hospital was tachyarrhythmias. It's something that I always say, sort of laugh, and I said, what gets our heart racing? Not just the patients, but all the rest of us. When we see somebody's heart rate at 200, all the rest of us are like, oh God, okay, here it goes. But in reality, there's some really simple things that we can remember, and there's some, in pediatrics, there's some really sort of well-known entities that we see again and again, and so we'll go through those in detail. But the good thing is, we're in pediatrics, we don't see quite the same variety, or at least not as often, as some of the things that go wrong in kind of really badly deranged hearts in adults. I think we listed out the course objectives. We'll go over kind of, the basic kind of normal EKG and all of that, but I didn't want to, I know you guys know what an EKG is, kind of, the basics of it. I didn't want to make this how to read an EKG. I wanted you to actually have some examples too that you can look at, and we can talk about kind of why we have certain types of rhythm problems. My sort of, I think, not arrogant, but cardiologists think, we think that cardiac cells are pretty special. We think that they've got special properties to them, and it turns out they actually do. They're a little bit different than, say, the muscle cells in your leg or your arm. And that's mainly because they have their own ability to beat. They have an intrinsic ability to generate an impulse, an electrical impulse. Now, neurons can do the same thing, so we're not that special. But we think the cardiac cells are pretty special, and they can do this spontaneously, meaning that they don't need your brain to tell them what to do. So, when you pass out at night and you're so tired from a hard day at work, you don't have to tell your heart to keep beating. It's going to do it on its own. If anybody remembers, I'm dating myself, Indiana Jones and Temple of Doom, he reached in, he took out the heart, he held it up, and it was beating there for a couple seconds. That actually can happen. The heart does not need the brain to tell it what to do. The cells there respond on their own, actually, to changes in electrolytes, mainly calcium, across the cell membranes, and those generate those way back in physiology and biology action potentials, and those action potentials which essentially act as your kind of impulses, electrical impulses, help transmit electrical signal from cell to cell within the heart. The manner in which those impulses are generated and spread give us our normal heart rhythm. And so whenever something disrupts that, when something interrupts it, when something creates an alternative pathway, that's going to lead to a dysrhythmia. I did want to just put out one of the things which I think is really important, but just what is an EKG? An EKG really is the physical manifestation. It's a visual way of representing the electrical activity of the heart. Most of us, I think, I certainly am a visual learner. I like to be able to see what's going on. And so the EKG allows us to do that with all the electrical circuits in the heart. It varies with the age of the patient. So a 2-month-old, totally different than a 20-year-old. Many things are going to be similar, but there are some really important differences that see, and the values, what we think is normal, just like in so many other things with kids, varies depending on the age. So things like how long, what's from as simple as what's their heartbeat, a normal heartbeat in a newborn versus a normal heartbeat in a 20-year-old. Those are going to be vastly different. And one of the things that we find sometimes, and you'll hear us say all the time, is that EKG was set probably on adult settings because that 2-year-old is going 110 beats a minute, and it says kids in sinus tachycardia, when in fact that 2-year-old is mad and probably not really, and he's not really in sinus tachycardia, he's just mad at us. I had a little picture up there because I always think it's important to know where your leads are. I mean, you guys are the ones who put them on. You guys put these on, patients so that I can look at an EKG, so that your colleagues can look at an EKG. And I had put up here in one of the pictures I literally went to our EKG machine in our office and opened it, and I was like, what happens when you first open an EKG? This is what you see. Down in the little corner, there's a little thing called map, and if you hit that button, the map of the human body kind of comes up and it tells you where to put an EKG on. I remember, even as a student, when I was like, oh my gosh, how do I do this? How am I going to figure out how to do this? Well, they tell you. It's really nice. And knowing that, if we go down to kind of knowing where the leads are placed allows you to know when you're looking at an EKG or when something looks really strange, what area of the heart is it talking about? And so I had kind of shown up there, if you have, there's a picture, I think, of how the precordial leads are kind of stretched across the heart, starting with V1 on the right side and all the way to V6 over on the left. So that I know if somebody says, somebody's coming in and I'm worried about something like hypertrophic cardiomyopathy or left ventricular hypertrophy or big, thick left heart, where am I going to look at that? Where am I going to see that most? I'm going to see that in the leads that are closest to the left side. If I'm going to worry about somebody with right-sided heart failure and a big right side or a big volume overload, where am I going to see that? I'm going to see that in like V1, where it's almost right over the right heart. In pediatrics, one of the pictures I had up there does show the V3R and the V4R. Those are pediatric right-sided leads. And those we typically use in younger children, because younger children are a little bit more right heart dependent than adults are. And again, popped up there the normal EKG with those pictures for you so that you could kind of see where, if you've got lead 1, lead 2, lead 3, where those are on the EKG. And so again, kind of just where to look for all of that stuff. The next slide that I had, I kind of went through just what the normal conduction is, because I wanted to say, well, now we know, yes, we know kind of what the basic EKG looks like. We know where to look for things. Oh, sure. Ah, look, he's got the signal. Let's see if we can get this thing up. Sorry, give me 1 second. There we are. I don't know that it's showing up here. Or maybe it's, reconnect. I don't know how to know whether that's.
Yeah, those are the days.
I don't remember.
I know, I feel like I need an overhead projector with little blue and green and yellow and.
In my EKG class.
Okay, all right, so he'll plug that in and we'll kind of go through again, the normal conduction of the heart. Knowing how the signal goes through the heart allows us to then say, okay, when something is deranged, why is it deranged? So what we had shown, which we'll show in a couple seconds, is the pacemaker of the heart is a sinoatrial node, or the SA node. It's up in the top right part of the heart. It sends signal out when it wants to start a heartbeat. It sends that signal out sequentially, and that's something that's really interesting about the atrium, is that those cells fire one by one by one in a wave. And that electrical impulse goes through the atria in a specific pattern from the top right down to the, there it is, down to the apex on the left of the heart. Down. Actually put the background so it's not just plain white. It's not real that exciting. I get just did the slideshow. Excellent, yay! Alright, so we'll skip that, because that's all that. Not all that important. This is what I was talking about, the map, that's what you'll see. And here we go. So normal conduction through the heart, there's a little wave. That goes over to the AV node, and the AV node is kind of the gatekeeper. It has to wait, there's a nice delay that's built into it, because the signal through the atrium, because it's going cell by cell by cell, those atria aren't exactly in synchrony. The right atrium, which is right where the sinoatrial node is, the SA node is, that's going to get the signal first, the left atrium is not. So you don't want the ventricle to beat, or you don't want the chambers to beat or the ventricles to beat before the left heart, the left atrium's had time to get all its blood. So there's a little intrinsic delay in the AV node to let all that happen. You get adequate ventricular filling, and then that went really fast. Which is good, because that's what it does. And then the signal goes down through specialized fibers, the bundle of His, the Purkinje fibers, so that the delivery of the signal to beat the electrical impulse to the ventricles is almost simultaneous. There's maybe a tiny bit faster on the left side than the right side, but almost undetectable. And that's because it's not really efficient. If one side of the heart beats at a different time than the other side of the heart, because one side's going to push the other one over, and what you really want is the whole thing contracting together to get efficient contraction, efficient ejection of blood and good cardiac output. So if those pathways are deranged, then some part of the heart's not going to get signal in the same way as the other part of the heart. And we'll talk about that when we get to the actual reviews. I just did kind of pull up the kind of normal QRS-T complex so that you know when we're looking at the different parts of the heart, because different tachycardias are generated from different parts of the heart and affect the QRS in different places. The P wave is essentially the depolarization of the atria. That's your main, that's your initial signal through the atrium. The QRS, of course, is the ventricular depolarization. It's the electric activity, primary electrical activity of the ventricle, and then the T wave and the ST segment, which I don't think we could clearly put up there, but the ST segment and the T wave is the repolarization. It's kind of the resetting of the ventricles. There's actually a resetting of the atria too, but it's just such a small amount of signal weight that it gets buried and lost into everything else. The intervals that we look at are the PR interval. That actually includes the contraction of the atrium, includes the depolarization of the atrium and the AV delay. So things that change that, the delay in the AV node will lengthen that period of time. The QRS duration is just the time it takes that electrical activity to get through to depolarize the ventricle. And then the QT interval, which you hear us talk about, especially in relation to certain tachycardias or potential tachycardias, is the time from the start of the Q all the way through to the end of the T. And again, deranges, and when there's a derangement in that, you can get some pretty significant tachyarrhythmias. This is mostly just to summarize, the EKG is kind of a visual manifestation of the heart's electrical circuit. And knowing those pieces, I think, helps us kind of understand and determine what part of the heart is having trouble and which part is not doing what it should be. So now there's a lot of ways to classify arrhythmias, and Arrhythmia is simply a word that means, from Latin, it means irregular heartbeat. There's actually benign ones, and there are kind of normal arrhythmias, sinus arrhythmia, for example, where there's a normal variation in the heart rate with breathing. And then there are arrhythmias that are slow heart rates, and there are arrhythmias that cause fast heart rates. Today we're kind of talking about the fast heart rates. You can classify them in a lot of different ways, and that sometimes leads to some confusion because there's overlap. But you can have arrhythmias that come from the top part of the heart, or the atria. You can have arrhythmias that come from the ventricles. You have arrhythmias that come from the junction, or the mid portion of the heart, kind of where the bundle of His is, above where it divides into its left and right branches, but still within that 80 node and the sort of fine fibers in the middle of the heart. You can do it based on how those arrhythmias or how those irregular heartbeats are generated. Is it something that happens automatically? It's a cell that's kind of off on its own, doing its own thing? Is it an accessory pathway? Is it something that's re-entrant, where it starts a short circuit loop that you kind of have this very fixed tachycardia? And then there are some pretty rare ones, which is something like triggered, which has components really of both. In kids, primarily, what they, and then there's probably the, then there's probably the most important one, which is the one that I classified it with, which is narrow versus wide. And the reason I like that one is that's what you see. So a lot of the other stuff is a little bit academic, right? It's what the cardiologist says. This is an automatic type. Once we've decided what tachycardia we have, we can tell you, oh, this is an automatic tachycardia. This is a reentry tachycardia. This is, something else. But what you see when kids walk into the ER, when you put them on a monitor, when you get an EKG, is you see either narrow complex or wide complex. And that kind of starts you down your path of A, how much do I worry? And B, where do I go next? So that's where we'll go next. Narrow complex tachycardia just means the QRS interval, the QRS duration, is generally under about 100 milliseconds, adults to about 110, so that's narrow complex. Wider than that is going to be a wide complex tachycardia. Narrow complex tachycardias typically come from above the atria, above the ventricle, so that can be from the junction of the heart, or it can be from the atria. So that's one of the reasons why the classification of just atrial versus ventricular doesn't work. Wide complex tachycardias generally are from the ventricles, but then there are some atrial tachycardias that mimic them. And so not every wide complex tachycardia is truly a ventricular tachycardia. And so that's where that overlap kind of comes in. And I apologize because this is a little bit small, the writing's a little bit small. But this is just another kind of way, this is just sort of a nice kind of way to line them up. The ones that I really want to talk about, I think we'll go, oops, that's what I want to do. I think the ones that we see the most are the ones that we're going to talk about in detail. That's the accessory pathway mediated tachycardias, or what everybody calls SVT, which is kind of a catch-all phrase. It's kind of a junk phrase for anything that's above the ventricle. We do see fib and flutter, and I'll show you some examples of all of these too. And actually, in this category of automatic, what we see, besides sinus tachycardia, which we see lots of, is atrial tachycardia and jet, or junction-like tachycardia. Depending on where you are, those are some things that we see actually not uncommonly. Not so much walking off the street, but definitely something that we see in some of our sicker patients. And then we'll touch a little bit on some of the wide complex tachycardias. But luckily, wide complex tachycardias are pretty rare in kids. It's not something that we see it's not something that we see all that often. I'm going to do this a little backwards. I'm not even going to talk about triggered tachycardias because they're so unusual, they're so rare, and there's got components of both the automatic and the reentry, the features of both. So we'll talk about automatic tachycardias very quickly because those are also pretty rare. They account for less than about 10% of the narrow complex tachycardias that we see, or the tachycardias that we see. Most of what we see, and especially kind of the classic baby that comes into the ER, is going to be reentry tachycardias. Automatic tachycardias come from a random focus of cells, or a cell that just decides, hey, I'm better than everybody else, or I'm different than I want to be different than every other cell. I've got that property that's native to me. I'm going to go at whatever rate I feel So an atrial ectopic tachycardia is going to show up with an atrial rate that's kind of, or a P wave that's kind of doing its own thing. They are different than the reentry tachycardias, and one of the ways to recognize them when you see them is that they don't have the same kind of fixed rate started all of a sudden. They tend to warm up. There tends to be something, whether it's an electrolyte imbalance or a change in the membrane threshold that sort of starts them up. So they tend to start up a little bit slower than a reentry tachycardia, and then they cool down. So they actually, as somebody calms down, as the adrenaline their adrenaline drive kind of slows down, or their vagal tone kind of takes over, they tend to slow down. They don't tend to suddenly go on and off, which we'll see with reentry tachycardias. The rate can be variable because of that. So sometimes, if there's a kiddo with an atrial tachycardia and we're worried about it, and he comes in and he's kind of got a rate, and then we stick him with an IV, that rate goes up, and then he's like, okay, IV's in, not so bad, that rate comes down, but it's still faster than normal. It's still a tachycardia, it's higher than it should be, but it has that property of being able to respond to changes in the physiologic state or the milieu of the body. They can be